Welcome, Elizabeth de Herder, to the Virtual Hand Therapy and Surgery Summit. I just want to mention that we all call you Abby. So as I do throughout our talk, people understand the context. But thank you so much for being a presenter at the summit. I'm extremely excited. And I just love our audience to get to know you a little better. So welcome, and do you want to introduce yourself to us?
Well, thank you for having me. This is kind of exciting. So I have been a therapist since 1983. Started out in the burn unit, actually. Worked there for 2 years and then moved in 1985, and that's where I actually got my first position as a hand therapist. I had a ton of orthotic experience working in the burn unit and also tissue healing. And so that was, I guess, attractive for them to hire me. And then the rest of it was just amazing. I worked at University of Alabama, worked with 5 hand surgeons, 4 hand fellows. We were actually the trauma center for the whole state. So we saw anything and everything came through us. Then in 1989, I moved back to Charleston area, Charleston, South Carolina, and I worked at the Medical University for a number of years, working with a hand surgeon there, which I now still work with. 29 years we've been working together, and that's pretty special. So I left there in 2000 to open up my own practice, and I've been there ever since. So we have 2 locations, and now I work with primarily 4 hand surgeons, but really anything and everything that will come to me. But really closely with 4 really good hand surgeons. I've been treating tendons my entire career, whether they were burns or hand injuries. In fact, the hand center in Alabama, we got the really bad hand burns, the ones that, the tendons were exposed. And I actually started a new protocol with them because they used to pin the PIP joints. And I'm like, oh my gosh, they're so stiff once I get them. So I'm like, let's don't do that. Let me try this. And I would splint them correctly, and I would go into the tank room and actually just move their PIP joints about 30 to 40 degrees where I could actually see the tendons because they were exposed. And that made a huge difference in the outcome for the patients. Little inconvenient for me because they would call me and I'd have to leave whatever I was doing to go do that and then come back to whatever I was doing before, but it worked. And so that's kind of where I started even writing protocols, because we were the center for the trauma center, and we send these patients out to other therapists in the outlying areas. And that was before we had certified hand therapists. That didn't come about until 1991, which I sat for the first exam. Oh. But so the doctors asked me to write up based on research, protocols or guidelines, so to speak, that the other therapists that we sent the patients out to would follow. So we're doing the same standard of care. And so I kind of started doing that and just doing the big things like the flexor tendons, extensor tendons. Those are the things that were the most crucial things that we did. So I probably wrote up maybe about 10. And I kind of kept doing that throughout my career, because even when I worked at MUSC, we were still referring out to other therapists. And even now we send out to Hilton Head, to Columbia, people that are living 2 or 3 hours away, but still come see our surgeons. And the doctors want the same standard of care. So we send a copy of what they want, the particular program that they want, to make sure that we're all doing the same.
Amazing. So it is interesting how what we actually become known for is something that is almost forced on us early on in our careers. So we grow the skill. So tell us a little bit about the book that you've written, because you say you started writing protocols, but you've actually written a book on the protocols.
Well, I did. So about every 5 years, I would revisit these because I was a big believer and still am that I want to base these on research and what is, what is out there, what is safe, what is the evidence that it's actually telling us in research and what we can and can't do. And so about every 5 years, I felt like I needed to update that and have new evidence to base what we were doing. And I was revisiting the protocols, and I had written a couple more. Every time I would do it, I would write a few more. And I started doing even more. And one of my therapists said, you really should publish that. And I said, I think you're right. And we had some protocols out there, but they were old. The one that, of course, everybody knew was the Indiana, and it hadn't been revisited since 2001 at the time I wrote my first edition. And I still believe, then I came out with my second edition. And the reason why I came out with it 5 years later, one, to update everything, because there were some new things coming out, but also I didn't ever feel like the first edition was completed, because it took me a year to do it. And if I waited any longer, the research wasn't going to be current.
Yes.
So the second edition, I feel like it's more complete. It's 95 different protocols, either post-surgical or conservative. And it's 366 pages. And next time I'll add some more to it. But I feel like this time it was more complete. I just, and even this edition took me a year to revisit every single one of them. And I added something special in this one that I really like. I call it Clinical Pearls. And it actually, instead of just going through the protocols, it kind of says, what's the trend? What's on the horizon? Is this the gold standard of care? And all of it based on research. So I kind of liked that part, because you don't really mention that when you're talking about a kind of week by week protocol. So it gives the reader some insight into maybe some things that are trending, but there's not enough evidence right now to really say that this is safe. And that could change in the next 5 years, where more stuff is coming out.
That's interesting. So there are two thoughts that are crossing my mind. The one is, during the research, I think that there are many therapists out there who are quite intimidated by searching engines like PubMed, making sure that they have gathered all of the evidence, that they haven't missed anything, that they've got a system to keep track of that evidence. Are there any kind of tips that you can give us on that, and how you go about researching the evidence?
So I'm actually a clinical instructor we take students. So because we take students, I have access to the medical libraries. So I actually that's how I did it. And that's probably the best way. So if anyone is close to like a medical library, certainly look that up, Journal of Hand Therapy, the Journal of Hand Surgery, all those will come through there, but I also have access to both of those. So I kind of think it's fun.
Okay, you love it.
I love reading the research and finding new things. And whether it proves something right for me or proves something wrong for me, I think that's equally important. But I think it's fun. And some things that we know, like we've been taught for years, to do lateral blocking for a flexor tendon. Well, they just came out with an article in 2020 that proved that. We all knew it, but now we have the evidence to back it up. And so that was really just 2020. In fact, I think it came out after I had written the book. So definitely I will be adding that. And I did add it in my talk. So it's kind of fun to see that kind of thing come through. So every time I see the journal come through, I'm always searching and seeing what is something I can use.
And that brings me to the second thing that was on my mind was you mentioned trends, and you mentioned how often as clinicians, we feel it in our bones. We know we should be moving away from what's published and what is deemed to be safe. Also because surgery has changed. So for example, Walland has changed the way that surgeons can refer with confidence that that tendon will not rupture and will not gap if we position the MCP joints in neutral. And whereas before we didn't have that because surgeons, and well, even still today, we don't often have that unless the surgeon is using Walland. But I know for myself, having specialized in the casting motion to mobilize stiffness technique and applying it to tendons that are getting stuck and are not doing well, that, you know, I'm starting to develop a protocol for those patients, but it needs the research and it needs to be published. And so I wanted to know your thoughts on the type of research that you like. I mean, we have the various levels and we would all love level 1 and level 2, but what are your thoughts on level 4 and 5 and, you know, case series reports where you have clinicians who are applying techniques, recording these cases and publishing these cases and then sharing that with the world? Is that the kind of evidence you look at?
I do. I mean, I like to look at all of them, and I'm okay with just getting a case report, especially if the numbers are big. You know, I think that you have to, at some point, all medicine puts something at risk. But I think you've got to communicate with your surgeon, you know, and we've kind of talked about this a little bit, but I have gotten away from putting the MP joints in a lot of 60 and 70 degrees of flexion. I'm not quite as brave to put them in neutral. And I've discussed this with one of my surgeons that is pretty aggressive. And in a perfect world with that repair, it can be done. But again, I don't seem to get those perfect worlds. I mean, I get tendons that are cut, with a skill saw, and they've got a segmental loss, or it was a 2-week delay because it wasn't caught. So I tend to, if it was cut and repaired and everything went smoothly, I think that definitely can be done. But I don't seem to get those. I get the more traumatic and, a jersey finger that was 2 weeks before it was ever even noticed, and came into the surgeon and, by the time they repaired it, it was actually shortened. So I get those kind of things.
So you would say your protocols are more on the conservative side because of your experience?
A little bit, but also it's what I'm reading in research. And I have to say that the book that I wrote is probably geared more toward the learning therapist. I give them even guidelines on, do you do this with dressings on? Do you, I kind of, because I originally wrote it for therapists that didn't have a lot of experience. That we were sending out. There wasn't a certified hand therapist at that time. It was just a therapist that had done some dabbling in hand therapy that we were sending to. So I tried to keep it conservative, but I get good results with it. So, and I do go by what is out there and what is kind of true to the research. Now, do I do a few things on my own? And I'll write about that too. So there's a little bit of me in there.
Okay,
So,
good.
I've got a PIP joint. I have no problem, working on that joint contracture if I've got everything in flexion. So I'm not really putting stress on the tendon itself, but putting a little bit of stress on the joint itself. And I don't get as many, PIP joint contractures.
I think having spent so much time online with Dr. Lalonde, I think it's less about the position of the MCP joint and more about how much flexion you're demanding of your patient. And if you just say to them, I have that 4-finger rule, okay, week 1, week 2, week 3, week 4, they don't have to make a full fist. If they're just initially just making some motion, that's good enough. And I suppose that's where it would be so lovely for the young therapists to have all of your experience documented, because it's those little thoughts and tips and tricks that could give a patient either a really good outcome or not.
And that's what I'm trying to do. Like we do early active, and I actually start out with 2 fingers. So it's kind of a moderate, and it depends on the hand also. It depends on the size of the patient's hand. But as a normal rule, it's kind of the 2-finger. What I do like about that is that I can tell, I tell them just to touch my finger, not to push into it.
Yes.
And so if they're doing it too hard, I can feel that. What's interesting that, giving you a little bit of history, but when we started doing early active, it was back in probably in the 90s, early 90s. And it was the Indiana protocol, but also Roz Evans came out with hers. And that was done by a tension gauge, where she's the first one that said not to make a full fist, to do a moderate fist. And we used this little gauge to actually test, and you couldn't go over that amount of tension. I forgot what that little device was, but I chose her protocol to start with. And we were doing it with 2-strand repairs at the time. And now today we found that doing a moderate fist is much better and safer, and you get great results, and you don't need to do that full fist, which actually causes a little bit more stress on the tendon. So
And surgical techniques changed because, as Dr. Lalonde says, we don't want a grandma kiss repair. We want a really good repair, and whether or not they're venting the pulleys or not venting the pulleys. And, those little things make a huge difference to how we can then rehab our patient.
Correct. Oh, yeah. Things have changed so much. Now we're doing 4 and 6 strand repairs, where when we first started doing the early active, it's 2-strand.
It was 2-strand, yeah. Modified Kessler, 2-strand.
That's right. That's right. Sweating.
And I do remember being in big trouble from a surgeon because I had put my dorsal hood at 70 degrees of MCP joint flexion and not 90 degrees. And he was so upset. He came hunting for me in the hospital. And at that point, I just read an article to say that we must go into 70 degrees. But now I'm your neutral MCP joint in neutral therapist. And in fact, I love Jimbo Tang's work, where I actually remove any dorsal hood as well, so that the patient actively moves without it. And because we all know that the patients that remove their splints do better, and it's more about the education and just guiding them towards not using it, but moving it, and how much they're moving it. And as you say, not applying that force. And certainly now, I think if a few years ago I was doing place and hold, but now I definitely don't do place and hold. And I think that's what's really hard for the young therapists, is they go and do their homework and they research and they read everything. And it's all changing so rapidly in the surgical and therapy realm that when they come to actually seeing that patient can all become quite overwhelming for them.
Right. Right. And you're a little braver. We still do place and hold with the early active. But you're right. I mean, I have a patient right now that he just is having a hard time understanding, and the doctor put him in a Duran protocol, but he's moving his fingers. I mean, when I tell him to to take his other hand and push him down, he kind of takes them and then holds them there. I'm just like, okay, you're not understanding this, but he's doing great. But because he's really doing active motion.
Exactly.
Yeah.
Exactly. And yeah, so where do you see tendon rehab going? I mean, what do you think would be the ultimate protocol in the ideal situation?
I mean, I think what you're saying is doing the early active. I think, but having them actively move the the tendon. I think it's going to be hard in the US to get some of that, because if you rupture the tendon, you're starting all over again. And it's more difficult because we're not socialized medicine. Lawsuits are all over the place. And so I think as a general rule, America tends to be a little bit more conservative because of that, as opposed to Canada, even the UK, where they have a little bit more freedom to do that and the lawsuits aren't there.
So let's talk about Wallant, because you've written the Wallant protocols. And that is where I've been able to change my protocol, simply because the surgeon can assure me that his repair is strong. There will not be any gapping. He's tested it on the table with full extension. And so just to reassure you, the first 2 weeks, I actually put the patient in 10 to 20 degrees of MCP joint flexion before we go into more neutral, by which point we also often, if they are struggling in week 3, starting to use SIMS as soon as I can see that there will be an issue. And it's all about positioning that patient to obtain glide. So now we've got Wallant, and that is also slow on the uptake in theaters across the globe, because as much as Dr. Lalonde is working hard to educate, it takes a lot to change how people work. So I've been very, very lucky, and I work just in private practice. So tell us a little bit about your experience with Wallant and how you came to write the protocols for Wallant.
Well, active, one of my surgeons does do the wide awake. So she actually doesn't use a tourniquet, just exactly what they say, because that actually will, they may not be able to make a fist with the tourniquet because it takes a while once you let that down. So she uses the epinephrine so there's no bleeding, and then repairs it and watches it as they actively move through. So she does do that, which is kind of nice, because all her tendons, she wants early active, early active. Some of the other doctors don't do that, so we don't know the repair. And she's even told me, I've had a gap and I had to take it down, redo it. So that's kind of fun to work with different doctors.
Yes.
And she's definitely more progressive.
Is she getting better results?
It depends on the patient, which is very interesting. I've got an early active right now that she cut her index finger, FDP, but she can't even move her other fingers, which I'm just like, you didn't cut these. I don't understand. Still, but she also is doing her exercises like twice a day. So I'm like, I think the patient, getting them to understand that hands like to move, and you can't, she's almost 3 months out and I'm still working on a stiff hand. The tendon is fine once I get it moving, but she just can't keep it moving. She didn't take the time to do it. So you're always going to have those patients. But as a general rule, my attendants do well no matter what protocol I use if the patient's compliant. I know a lot of therapists don't use Kleiner. I have. And I tell them, though, to exercise every 15 minutes, not every hour. And the more they do, the better result they get. So I've kind of found that not all fits in, one size doesn't fit all. And, we kind of talk to the doctors and what we're going to do, and then we follow through. But I've gotten good results with Duran, Kleiner, Early Active, just as good.
But I think that's really where your talk, what you're going to cover in your talk, is how you use your therapeutic use of self, plus your experience, plus all the tips and tricks and different protocols and everything in your toolbox to work with that particular patient, how they're presenting in their personality and how they're presenting with their tissue, and taking into consideration all your experience with tissue healing and your gut feel of where that patient's going, whether or not you can push them or you need to hold them back, and what approach to use with them.
Yes.
Yeah, it is. It's such a fascinating topic, and I do look forward to our panel where we're going to have 4 experienced therapists talking about different techniques and approaches that they use. And can you tell us a few tips, or is there one thing you want to share with us that you're going to be going into detail with in the course? Not in the course, in your lecture?
I think we've already touched on that. Is the big thing that I wanted to get is that there are all these different tools that we have used, that the protocols, we've got all these things at our disposal, but not all one, it doesn't fit into a box. We've got to make sure that we look at the patient individually, the injury individually, and how to do that, how to tease that out to make sure we're doing what's right for the patient.
And what is your book called?
I actually have a copy of it right here.
Great. Do you want to show everybody?
Evidence-based hand and upper extremity protocols. And this is the 2nd edition.
And so you cover all treatment, not just tendons, in that book?
Oh, this is everything from into the shoulder. So we treat from the shoulder down to the fingertips. I mean, anything and everything, the elbow. I probably don't have as much detail in the shoulder, but I do have some. And in doing my research, what was interesting is I've even changed some things that I've treated differently and gotten some really good results because of all the research I've done.
Okay. And are there any kind of modalities that you're using now, or techniques that you're using that you weren't using before? So for example, for me, my new love is kinesio tape and tuning forks. Is there anything that you're using that you're finding is your go-to?
I just got certified in doing dry needling. So I found some good things with that. The kinesio taping, I've used some. I wouldn't say that I'm use it a whole lot, especially with tendons. One for extensor tendons, I love doing the extensor tendon acceleration. I get, especially when you've got that extensor lag, like over a P1 fracture, that's just so hard to undo once it happens. And if you've got somebody that was pinned, the pin, and their PIP was sitting in a little bit of flexion, it's just real hard to get rid of that once it's established. And so I love using the acceleration technique, which is documented in the book, but also you can find it in literature.
Oh, okay. That's something I'm going to look into. So that's what I love. What I love about these conversations is because we plant seeds, right? And I think it's so easy to use what's in your toolbox, and it's so much fun to start having new tools in your toolbox. And this is where we can share those with each other, which is great. So just in closing, before we end, I just want to say that book is a phenomenal resource, and I just want to congratulate you on taking the hours, because we all have our skills, and we all have our comfort zones of what we love to do and where we love to go deep into research and learning. And not all of us can do what everyone can do, but you've provided us with a shortcut. You've provided us with a reference that I think can benefit so many therapists, especially when they're working in very big, busy hand units, where some therapists are seeing patients every 15 minutes. It's very overwhelming. It's very exhausting. They get to the end of the day, and you have great intentions to open up all the textbooks and get online, but very often you're just swamped. You having to still do your clinical notes, still having to, tend to your families and live your life. So I think by dedicating your life and your career to this, you are definitely going to be helping so many people. So it's a wonderful resource, and I really just hope that everybody can get the book. Where can they get it? Can they buy it off Amazon?
They can. It's on Amazon. It's also on my website, which is charlestonhandtherapy.com. And, I use this book. I can't keep everything in my head. And also I'm like, okay, is that 3 weeks or 4 weeks? And I tell people I will never speed up a protocol without talking to the doctor, because this is all based on research, but I'll certainly slow it down.
Okay.
If I feel like somebody's looking a little too good, then I'm always worried about, is there enough scar tissue in there? Is it healing properly? We can't see that. So, and we've talked about that a little bit in the book too.
That is interesting, because it was a recent discussion in our recent Flexor Tendon panel. And yes, speed up or slow down. It actually can be a debate for our next panel, because what Dr. Lalonde was saying, because it was with Dr. Roulette, Dr. Lalonde, Jennifer Sager, and myself, what he was saying is that we've all been taught that from 3 weeks, that tendon can be weaker. And that's the point where it can rupture. And so we tend to slow our patients down. But actually what he's saying is that's when there is scar, and that's when we've got to work through that scar. And if we slow them down too much, we can actually not get that glide that we are hoping for, particularly that differential glide of FDP and FDS in 1 digit. So this is why I love panels, because we can actually debate those topics, and it's never going to be the right answer, because it's always going to be dependent on the patient, how much scar tissue they have. In our population, with black skin versus white skin, there's a lot more scarring, and a lot more Black people have keloids that we would have to overcome. And so, you're not going to hold that patient back. You're going to try and push them through. So it's your patient population that is really important. So yeah, it's fascinating. And I think that we can talk for hours, and I do look forward to your presentation. And I'm sure the therapists are going to learn so much, and you are going to be making it quite practical so that they can think in their next session about what to do. But I just want to reiterate, as you say, even though you wrote the textbook, you refer to it. You cannot hold all of that in your head. And it's great to be able to go to that textbook and say, all right, what does Ebi say? Should I push through? What should I do at 2 weeks, 4 weeks, or whatever with the different protocols? And I love that it is the whole upper extremity with different problems. So, and then people can get in touch with you. So through your website, through your email address, but I think that there'll be a lot more questions once they've heard your talk. But Abby, thank you. Thank you very much for spending the time with me so that our audience can get to know you. And I'd love to see what you continue to do. I mean, you've been in your career for 39 years. There's still a lot of time left. So do you have any ideas of what you think you'll do next?
I know that I'll do a third edition, probably in the next, it's been 2 years. So probably, unless something really comes out earth-shattering that's really new, definitely, let's say I put out this one in 2020. So probably by 2027, I will definitely be working on that and getting that out, because I do believe that we have to revisit at least every 5 to 7 years. And again, it could be sooner. It just depends on what happens in research and where we see it going. And I'm going to continue to practice for at least the next 5 years. And I still work full time. I just started going and not taking Mondays off. So that's huge for me.
That is huge.
But then I will use it for things like this and my writing time. So it's, because when I wrote the book, I was working 40 hours in the clinic and doing the book. That was a lot.
I know. Well, you've inspired me because I want to publish, I'm basically with my students in the Sims Club, because we're all over the world and we're all getting a lot of these cases. We're going to use Sims with the Flexer tendons and try and get a really good case series report on the protocol that I've developed. So hopefully we can publish it in time, and it's something you can review, and we'd love to have your contribution actually in those early stages. And then maybe it's something for your next, there can be a contributing factor in your next book where we could look at. Do you use Sims at all?
No.
Okay, so it'll be something new for you.
I would love to learn. I'm always there.
Yeah, well, that'd be good. So I think that this might be the missing link, just from our experience and what my students are doing. It's one thing doing something yourself, but when your students are starting to do way more than you're doing, and they're getting amazing results. And that's when I'm very inspired to put pen to paper and publish it and get those case series out there so that it can form part of the evidence for exactly moments like this when you launch a book in 2027.
That'd be great.
That'd be great. So we've got a path to walk.
Right.
Well, we really look forward to your talk. Thank you so much for your time. And we can't wait to see